Welcome to the Physiology Case Scenarios, Cardiovascular Series, Part 1. This module deals with cardiac electrophysiology. Case 1. A 45-year-old man with a history of poorly controlled type 2 diabetes mellitus and evidence of deranged kidney function is admitted for glycemic control. His earlier electrocardiogram showed tall peaked T waves. The ECG on admission showed flattened and wide P waves and prolonged PR interval. His potassium in the plasma is 6.4 millimoles per liter. Which of the following electrophysiological alteration in the cardiac muscle is attributed to his elevated potassium level in the plasma? Options are: decrease in the magnitude of cardiac action potential due to reciprocal changes in the alterations in the plasma sodium concentration. Option 2, decrease in the resting membrane potential and decrease excitability of the conducting system. Hyperpolarization of the cardiac myocytes and delay in initiation of impulses. The last option is inhibited sodium potassium pump and unstable resting membrane potential. So if you look at the case, here is a case of a man with type 2 diabetes mellitus which is poorly controlled and evidence of renal function which is deranged. And his ECG shows all signs of or evidence of hyperkalemia. So with the slight increase in the plasma potassium, he had tall peaked T waves. Then his potassium is quite high now, 6.4. Normal is 4 to 5. Now he is showing wide flattened P waves, prolonged PR interval. So what has potassium done to the cardiac muscle? Elevated ECF potassium. You know that potassium is an intracellular cation. So at rest there is an efflux of potassium due to the concentration gradient. Inside potassium is more, about 150 millimoles per liter. Outside, so the ECF is about 4 to 5 milliequivalents. So there's a large gradient. Because of this, there is a efflux. That's the basis of resting membrane potential. Now, if the plasma or ECF potassium is elevated, what would happen? The gradient is decreased. So now, if you look at this physiology, what option would you like to pick? Because potassium, ECF potassium is more to do with the membrane potential, we have already seen. So it will not decrease the magnitude of action potential because it's something to do with the sodium influx. And potassium level changes will not cause reciprocal changes in the plasma sodium concentration. Never marked alterations occur. So A is out of question. B, decrease in the resting membrane potential. When you say decrease, it means it is less negative. Minus 80 becomes minus 70. That is 70 is less than 80. The minus has no arithmetic value. It is only to show that inside is negative. So minus 80 RMP becomes minus 70. It is decreased. Will it decrease really? Yeah, because it will decrease when there is a decreased gradient, potassium gradient across the cell or membrane, cardiac cell membrane. The efflux reduces. So cell tends to get slightly depolarized. That means the membrane potential is decreasing. It becomes less negative. So that's the first part is correct. Which will lead to decreased excitability of the conducting system. Yes, if there's a marked depolarization. If it goes above the threshold, and it will go in for a refractory state and the excitability is lost. So B is the most likely answer. C, let us look at a C. Hyperpolarization, delay in impulse, hyperpolarization will not occur. C is out of question. Inhibited sodium potassium pump is not correct because elevated potassium will not inhibit sodium potassium ATPase pump. Resting membrane potential does not become unstable, it becomes less negative. B is the most likely answer. Decrease in the RMP, decrease excitability of the conducting system. Case 2. A 38-year-old female patient who has thyrotoxicosis is on a beta-adrenergic blocker since 4 years. Presently, she has developed drug-induced bradycardia. Which of the following in the recording of a say node action potential is most influenced by beta-adrenergic blocking agent? So you have action potential recorded. This is from Pacemaker, SA node. This is a typical SA node action potential. Unstable membrane potential shown by the phase A, sometimes called as a slow diastolic depolarization, or the pacemaker potential, phase A. Slow drift of membrane potential towards the threshold. So from minus 70, it has reached minus 40 to threshold. Where the action potential is fired, phase B starts, and the phase C is the repolarization. And again, when it reaches the resting value, which is unstable, again there is a drift. So this continues, and this is the cause of the rhythmicity or self-excitability of the pacemaker. The phase A is actually the cause for the rhythmicity or automaticity, and this is affected by various drugs including the catecholamines and acetylcholine. So whenever the action of these drugs are inhibited, blocked, phase A is most likely to get affected. So here is a drug, beta-adrenergic blocker, which has been consumed by the female for thyrotoxicosis to decrease the heart rate, has a side effect. Ultimately, she has come into bradycardia, that is decreased heart rate. So this is a drug-induced bradycardia, and beta-adrenergic blocking agent has caused this. So it must be affecting the phase A. Let's look at the option. Magnitude of action potential is not affected by the beta-adrenergic blockers. Phase A is the correct answer. Phase B is not the correct answer. It is affected by the calcium influx. Phase C is repolarization, potassium influx. There is another option. Threshold potential is not also affected by the drugs and chemicals or hormones. It's the phase A or the phase 4, sometimes called as in the actual recording phase 4. That is the membrane, unstable resting membrane potential. Let us look at the action of this blocker. What will happen? Blocker, not the adrenergic stimulation. The blocker causes bradycardia due to this effect. The blue that decreases the slope of phase 4 or the pacemaker potential by decreasing the calcium influx into the cell. When there is beta-adrenergic stimulation to the heart, there is increased calcium influx during the phase 4 or the pacemaker potential, and the phase A or phase 4 slope is increased. Here the slope is decreased because of the blocker. This is the opposite action of the beta-adrenergic stimulation.